Right now, I'd like to introduce our next speaker, Dr. Aman Chauhan. He is at the University of Kentucky Markey Cancer Center. Um Dr. Chauhan has been giving quite a few presentations uh, at our NCAN conferences, and I mean he's got a lot of things going on for NETs. He's the director of Net Theranostics at Marking. And what that means is, if you know the Theranostics or Lutathera or LU-177, that all means PRRT if you boil it on down. And that's what he's going to talk with us about today. So please welcome Dr. Chauhan.
Thank you so much, Bob. And it's always a pleasure to be here and talking to wonderful neuroendocrine tumor community, the patients, the caregivers, industry advocates. Thank you so much for giving me this opportunity. My name is Aman. I'm one of the medical oncologists, and I specialize in neuroendocrine cancers, both low grade and high grades. And I specifically focus on neuroendocrine cancer drug development and new clinical trials. Um, One of my big areas of both clinical as well as research interest is PRRT. And today I would be talking about some of the standard practices and what is coming up, the latest and the greatest of sorts in this area. And before I delve deeper into PRRT, I would like to first go over some basic concepts because although many of you might already know about PRRT, some of you might be unfamiliar or new here at today's meeting. So let's go over some of the concepts. All right. So let's familiarize ourselves with theranostics. I'm the director of NET Theranostics at Markey Cancer Center. What does theranostics mean? This is not the new field of medicine. However, this is certainly picking a lot of traction in recent years, and I'll go over the reason why. First, let's go over what is theranostics. Just to kind of highlight the importance of growing importance of theranostics in cancer, one of the leading oncology journal called the Lancet Oncology, you've probably heard of it, put the concept of theranostics on their cover page recently. So what is theranostics? When we use a targeted radiopharmaceutical agent to both diagnose as well as treat the particular disease or cancer, we call that concept theranostics. And what is a targeted radiopharmaceuticals or radioligand is if we attach, see, every lot of cancers have particular targets which are specific to that particular cancer. For example, let's take example of neuroendocrine cancers. You've heard that neuroendocrine tumors express somatostatin receptors. So imagine if we have a drug which likes to go and attach to somatostatin receptors. And if we attach a particular radioactive molecule to that drug, we can then use a particular type of scan to both isolate the tumors and visualize the tumors, for example, gallium-68 dotatate scan, and then later flip the radioactive molecule to a more stronger one and use that to target and then destroy the tumor. And in this case, Lutathera or lutetium-177 dotatate. But both are targeting somatostatin receptors. So same target is used, and just by flipping the radiopharmaceutical or radioligand, we can convert a diagnostic agent into a therapeutic agent. And this is very broadly, or in a very simple way, the concept of theranostic. The two leading drugs in this space, which really be the flag bearers of this concept currently, are lutetium-177 dotatate, which is Lutathera, and we'll be talking about it in detail today, and FDA approved for neuroendocrine tumors in the US. And the other drug, which is definitely coming up big time, is a PSMA or prostate-specific membrane antigen, which is expressed in prostate cancer, targeted PRRT agent. Novartis recently released that their phase 3 data for this particular their particular PSMA agent was positive in prostate cancer. So these are the two main indications where these PRT agents are currently used either as practice or clinical trials that are coming up. However, this concept is going to broaden in various cancers in the near future. As long as the cancer has a particular target and there is means to attach the radiopharmaceutical drug to that particular target, any cancer can be treated with this particular concept. For example, look at this slide. These are patients with pancreatic cancer, colorectal cancer, and breast cancer. And here what we are seeing is that these cancers tend to express a protein called FAP, fibroblast activating protein. So if you develop a drug which likes to attach to FAP and then tag that drug with gallium-68, do a scan, you can isolate these tumors. You can know exactly where the tumors are. And later on, if you flip this gallium to a stronger radiopharmaceutical like a lutetium or something else, you can use the same principle and then go ahead and treat the cancer. So this is the concept of theranostics. Now let's come back to neuroendocrine cancers and focus on NETs for today's talk. You've heard of NET-SPOT, gallium-68 dotatate imaging. Prior to NET-SPOT, we used to use an imaging called octreoscan. It used to be good for that particular time period. The information we got from octreoscan was whether the tumor were somatostatin receptor positive or not. But as you can see in this picture here, it wasn't a very clear picture. It was very blurry, and we got a general idea whether the liver mets here are somatostatin receptor positive or not. However, fast forward to 2016, and we have a very sensitive and specific radio, somatostatin receptor imaging technique called gallium-68 dotatate scan. And the same patient, you can see how clearly defined these tumors are. Even the small tumors, you can pick them up very clearly, which weren't easily visible on octreoscan. Based on this significant improvement in its resolution, the sensitivity, specificity close to 91%, FDA granted approval. It was a big step forward for the management of NET patients in the US, and we were able to get now a better idea of the disease burden. However, what gallium-68 dotatate is telling us is where the tumors are, and these tumors, do they have somatostatin receptors or not? The more the DOTA avid the lesions are, the higher the somatostatin receptors are, and that's what we are looking for primarily with the help of gallium-68 dotatate. Because if they do have that receptor, then you can target those with PRT agents, and we'll talk about that in a second. Also, very exciting development in this space. Very recently, FDA granted approval to another radio imaging agent for detection of somatostatin receptor positive neuroendocrine tumors called DetectNet. It's copper-based dotatate scan, and it's very similar to NET-SPOT. So they are basically interchangeable. Very equal, similar in terms of the imaging quality. So, they're providing us the same kind of information. So it's really good that now we have a couple of different options. So we have the scan, which tells us where the tumors are in the body and whether they express somatostatin receptors or not. And if they do express somatostatin receptors, as we talked earlier, the concept of theranostic, if we change the gallium-68 to a more stronger agent with lutetium-177, for example, we can use the same concept to now not just detect where the tumors are, but to destroy the tumors. Okay, this illustration shows us how this happens. So you can see here, this is GEP-NET tumor cells, gastroenteropancreatic neuroendocrine tumor cells. Okay, this one. If we look at the margin of this tumor, here you can see a somatostatin receptor, SSTR2 to be precise. There are different types of somatostatin receptors. The one we are talking about today, or the very common type, is SSTR2, the type 2. Now, if you have a drug called lutetium-177 dotatate here, okay? So the dotatate is what really likes to go and sit on the somatostatin receptor. Consider the somatostatin receptor like a lock and dotatate like a key. So when you get injected with dotatate, it likes to go, the key likes to go find the lock and then attach to it. In this particular concept, lutetium-177 is attached to dotatate. So if you attach a keychain to the key, so when the key binds to the lock, it also drags the keychain with it, right? And if that keychain is radioactive, you're basically taking a radiation or radionuclide specifically to the tumor only. So you save the normal tissue from getting unnecessary radiation, and the tumor is getting treated with smart radiation, or what I call targeted radiation. And that's the beautiful concept of theranostics here in NETs. When the drug binds to the somatostatin receptor, it gets internalized. These the compound together would go inside the neuroendocrine tumor cells, where the radiation would damage the DNA of the tumor cells. Okay, you can see in the illustration here, there are these cracks in the DNA, which is caused by the radiation. And that way, we save the normal surrounding cells, and only the neuroendocrine tumor cells which express somatostatin receptors get targeted by this radiopharmaceutical. Once the DNA is damaged, these cells cannot multiply and grow. DNA is crucial for the growth of any cell in the body, including tumor cells. And that's how we cause tumor cell kill. Now, this was the concept. You've heard about NETTER-1 phase 3 multi-center international clinical trial. I was a fellow at that time, and two of my mentors at University of Kentucky were integrally involved with this study. Dr. Lowell Anthony were one of the 4 data safety monitor board for this large international study, and Dr. Ed Bolin, who was at Markey Cancer Center, University of Kentucky at that time, was one of the leading investigators in this large clinical trial. So very, very exciting to get their insight right when this trial was kind of being conducted and then read out. So let's go over what the Lutathera or NETTER-1 study showed us. So this is a randomized phase 3 study. What does that mean? Is that there has to be 2 arms. One arm gets the study drug, which is Lutathera or lutetium-177 dotatate. The other arm has to use a drug which would be either the best supportive care or a control arm, or something that we can assess what these patients would have otherwise got if they do not have access to Lutathera. At that time, unfortunately, we did not have a lot of treatment options for NET patients, so it was considered appropriate that the control arm would use somatostatin analog, but at higher doses, because these patients had already been through the standard dose of somatostatin analog or sandostatin. So this was the study which was done in various centers throughout Europe and the US. And look at the results here. This is Kaplan-Meier curves of progression-free survival. What does that mean? How long are the tumors really stable or not growing on CT scans, right? The line on the top shows the PFS or progression-free survival curves of Lutathera, and line on the bottom is the control group. At the time of the publication of this really critical paper, the control group with somatostatin analog had median PFS close to 8 months, whereas the median PFS was not even achieved. It was so good that they didn't even achieve the median at time of publication. Now we know it's close to 30 months. And this is consistent with our previous experience with PRRT in Europe, that the PRRT can then keep the disease stable from somewhere from 20 to 40 months. So really good results, and based on these stellar results, FDA granted approval to PRRT. However, another really important criteria when we test drugs in cancer patients is to not just keep the disease stable and prolong survival, hopefully, we also would like to improve the quality of life of our patients. And quality of life was another endpoint that the investigator tried to measure at baseline and the follow-ups. And as you can see, patients who did get lutetium-177 dotatate showed significant improvement in their quality of life as well as compared to the control arm. So the drug is able to control the disease and also improve quality of life. So that's significant. How is this drug given? So this is a targeted radiopharmaceutical. It is an IV drug which is injected, and it's given once every 2 months for a total of 4 doses. That's how it is FDA approved in the US. For somatostatin receptor positive GAPNETs, gastroenteropancreatic neuroendocrine tumors who have at least progressed on frontline therapy or SSA. Now, when we do inject this infusion takes about 30 minutes. However, another drug, or not really a drug, but amino acid infusion is infused to protect the kidneys. And that infusion takes about 4 hours. So this stays roughly about 4 hours just for the infusion part. Of that, only 30 minutes is the Lutathera administration. The rest is all amino acid, which this particular diagram kind of shows. So when the patient gets admitted, we give some antiemetics or nausea medicine. Then we start the amino acid infusion half an hour, 1 hour before. And then we start Lutathera. And then we complete the whole amino acid infusion to get a total of 4.5 hours. So that's how the standard PRRT is done. Now, the critical question is, we have this fantastic drug, when to do or when to recommend PRRT to our neuroendocrine tumor patients. So our board answer, that means, we are all board certified oncologists and, specialists. And if somebody asks this question in our exam, we will say progressive metastatic somatostatin receptor positive gastroenteropancreatic tumor, right? So this is the standard answer. However, life is not standard, right? Only I wish if it was as easy as that, right? But that's not the case. So there are some clear-cut indications where it'll be a no-brainer to recommend PRRT to our patients. So if we have a patient with widespread bony metastatic disease and considerable amount of pain, bone mets can be very painful. So if somebody is very symptomatic from bone mets, that's a really good way to treat those. I'll give you the examples from one of our patients. This is a net spot from a patient, and here you can see the baseline net spot. There's hardly any bone in the body which does not have metastatic disease. Small metastatic disease, large metastatic disease elsewhere, and the patient was in a lot of pain. Patient got 4 rounds of Lutathera, and post Lutathera gallium scan, if you can appreciate, there is about 63% reduction in TBI, total binding index, or at least 65% reduction in total tumor molecular volume. Significant, but more importantly, patient had significant improvement in quality of life and pain. And that's why that's a pretty easy answer. If patients have progressive disease and they're second or third line, especially a lot of disease exists beyond liver, that would be another reason to consider PRRT. There are very few treatments which are approved, FDA approved, for mid-gut neuroendocrine tumor. So our choices are PRRT or Afinitor. For pancreatic neuroendocrine tumor, there are quite a few options. Again, these options vary from Afinitor, some VEGF inhibitors, and then PRRT. However, each of the drugs have their own side effect profile. So you have to see which drug would be better for which patient. But PRRT can be considered for progressive disease, especially extrahepatic setting. Now, if somebody has functional neuroendocrine tumor And we need a systemic agent, a drug which works everywhere in the body, and the drug to be able to shrink the tumor. The best chance of getting a tumor shrunk among the all approved systemic therapy agents is PRRT. Now, to put things in perspective, NETTER-1 study showed about 17 or 18% overall response. So 17, 18% patients showed tumor shrinkage. It's very difficult to show tumor shrinkage with a drug in neuroendocrine tumors just because the way these cancers are, these are very indolent and slow-growing cancers. Afinitor, the drug which is another FDA-approved drug in this space, has response rate 5 to 7%, so single digit. And somatostatin analog, another FDA-approved drug in this space, has less than 5% response rates, probably 2 or 3%. So putting things in perspective, NETTER-1 showed Lutathera is significant advance in terms of cytoreductive capacity of a systemic agent. So if we need the tumors to shrink, because shrinking the tumor does help us reduce the functional symptoms in many a times, this is the agent that we should be thinking of. Now, what are the gray zone where PRRT is not clearly the choice of the top choice, but there could be various top choices, and it depends on need of the hour, the particular patient situation, etc. And that would be liver dominant disease or liver only disease. So if a patient does not have disease outside liver and there is just liver dominant disease, then there are a couple of options. PRRT certainly is one of the options for progressive disease, but there are other options like embolization. And sometimes it works really well, especially if it's very limited disease, it's one lobe, two lobe, and local regional therapy can be very effective in controlling low-grade, limited amount of disease in the liver with good side effect profile. So there, in that scenario, we have a couple of options. The PRRT is not the only option. In our institution, we, however, practice or avoid Y90 radioembolization because in the era of PRRT, we want to limit radiation exposure to the normal liver. However, there are some studies which shows that it is safe to do Y90 type of embolization, at least in the short term. We are still waiting to hear the long-term follow-up data with prior Y90 and PRRT. So for the time being, we at our institution do bland embolization or TACE in certain situations if we do go with local regional therapy route. Now, the other area where PRRT can be considered, or it's a possibility to use some other agent, that would be mesenteric disease. Mesenteric disease means the cancer is around the small bowel in the mesentery. That's the tissue which kind of holds your small bowel to the abdominal cavity. So if there is disease there, traditionally our treatments don't really work very well in controlling mesenteric disease, and that holds true even for PRRT. So when I said that PRRT has good response rates, mesenteric disease is one of those where we often don't see a lot of responses in mesenteric disease. However, we do treat mesenteric disease because they do have somatostatin receptors, and my experience has been positive in this space. However, there are some publications that there could be a small bowel obstruction. After PRRTs, it's not uncommon to have pseudoprogression or a little bit of swelling, especially after first or second dose. As the tumors are dying, there's some inflammation around. So if it happens around the bowel area, there is a chance that there could be a small bowel obstruction. And if that happens, you have to be just cautious and cognizant about that. Certain centers do advocate a little bit of steroids if that happens to help calm down the inflammation. But that's one area where maybe multiple options can be considered and discussed to see which one would be the best for that particular patient. So those were some not so straightforward indications. The other ones would be if the blood counts are low. One of the concerns with PRRT is that it can have bone marrow suppression from the radiation. So if the patient has prior exposure to Cape-TAM, and which can also cause bone marrow suppression, or if patient at baseline has low platelet counts, low white blood counts. Platelets are especially a lot more sensitive to this, then we have to be very careful and proceed accordingly. If patient has a very low volume disease, so there are patients with just maybe one or two small tumors. So if somebody has 1 centimeter tumor in the liver, or one lymph node or two lymph nodes, those are the very low bulk disease, and I would definitely not advise doing PRRT, because PRRT is a systemic radiation. We should save that for when the patient does progress or has larger volume disease. So if the patient has very minimal low volume disease, that's probably not the right indication for that patient. And lastly, if the patient's tumor does not have somatostatin receptor. See, this drug works only if you have somatostatin receptor. Lutathera, which is lutetium-177 dotatate, is a radiopharmaceutical which targets somatostatin receptors. If the tumors don't have somatostatin receptors, then there is no lock, so the key cannot go and bind to the tumor. So if that's the case, Lutathera is not indicated. Fortunately, grade 1 and grade 2 tend to have plenty of somatostatin receptors. This is the situation we often incur in higher grade neuroendocrine tumors, where grade 3, where not all the tumors or metastatic disease express somatostatin receptors. So that is the reason why we do a gallium-68 dotatate scan, the net spot scan, to screen the patients whether they'll benefit from Lutathera or not. All right, so those were some areas where we have some options to consider, including PRRT. Now, certain indications where PRRT should not be done, which are clear no. So these would include a pregnant patient, because clearly we don't have safety data. When we do these clinical trials, we try to screen patients who are pregnant or at risk for pregnancy, because it can be detrimental to the fetus. This is a radiation-based treatment. It could be teratogenic. Now, I did discuss about low platelet counts. Now, if the platelet counts are so low, and I would put a arbitrary, I'll give an arbitrary number, 75,000 or less. At least in our center, we'd say absolute no. Because if somebody is starting at 75,000 of platelets, then the chance that after PRRT, 1, 2, or 3 dose PRRT, they'll bottom down so much that they can bleed out from thrombocytopenia very high. So we don't want to take that chances. We should always consider other therapies if our starting point is so low. Then, as I mentioned before, if there are no somatostatin receptors on gallium-68 dotatate scan, then there's no point to give PRRT, because there's no lock to attach the key. If the patient has baseline hepatic insufficiency, if the liver is not working well, that's another area of concern. When we study these drugs, the patients who are tested or have normal liver and kidney functions. So we don't have safety data on patients with very high 2 or 3 time elevation of bilirubin. So that would be a concern. Kidney problems, if somebody has significant kidney problems. Now, there are some anecdotal cases from some centers with poor kidney functions, and PRRT has been done, considering risk, benefit, and limited treatment options. However, the standard indication we would basically avoid PRRT if the kidneys are not kidney function not optimal. And lastly, like any cancer treatment, patient should have a good performance status. That means functional status, baseline physical fitness. If somebody is so weak, so frail, and is not able to, is in the bed or recliner more than half a day, that patient can have worse outcome with any cancer treatment, because our treatment can potentially have toxicity. So with the performance status of 3 or over, this is something that you need to discuss with your oncologist and look why the performance is so poor. Is it something that can be reversed with the treatment, or is it because from the recent cancer progression? And so there are these things that you need to discuss with your cancer care provider and take the call. But there's always a concern. We know from prior studies, the patients who are fitter to begin with do the best. and the patient who have very poor performance status or very unfit to begin with, they can suffer more from cancer treatment, from the complications and side effects. Now, certain points to ponder regarding PRT. Such a new therapy is FDA approved in 2018, so we are still learning more and more about it. This is a significant advancement for us in our field, and the drug is very, very safe, usually very well tolerated, and is very, very effective, as you see in the response rates and the median PFS. It is probably one of the best drugs out there for metastatic GEP-NET management. Some things to ponder here is there is some data to suggest that if PRT is used early on in the treatment course of neuroendocrine tumor patients, it might even show better results. However, these are retrospective data, and we need to look these things in clinical trials. So with our treatment options expanding, now the next big burning question is, should PRT be done in the second line, third line, fourth line? So there is some data to suggest if done earlier, might be better. However, these are weaker data, so we look forward to seeing some prospective studies done for sequencing and seeing does it matter, and if it does matter, should we do it sooner than later? So that's one thing to ponder over. The other issue regarding toxicities, based on the current data which is available, and we have now a few years worth data after its FDA approval and prior to FDA approval from clinical trials, it seems that the side effect profile is not as scary as earlier we believed to be. The kidney toxicities, we don't see nephrotoxicity in our patient population, so that's less of a concern now. I think the amino acid infusion does a great job in protecting kidneys from radiation damage. So we have not seen nephrotoxicity as an issue. And even the bone marrow toxicity has not been seen as a major issue. The blood counts dip down. We have often seen that even those patients, there is a good recovery. However, radiation-based treatment has more chronic bone marrow toxicity concerns. That means MDS or leukemia risk down the road. Based on the current retrospective data or smaller single center data, this risk hovers around 2 to 3%. So it is small. Nevertheless, it's not 0%. So something to consider. And we will continue to follow the NETTER-1 long-term data to see what this rate truly is. And then lastly, PRT is a fixed dose regimen, right? So there are 4 doses which are FDA approved. So there is a lifetime maximum limit of the amount of radiation you can do to a human body. So if somebody does a 4 round of Lutathera and then had a good outcome and in future needs more radiation, you cannot just keep giving more and more Lutathera. However, there are some data supporting 1 or 2 additional doses in those who did benefit earlier. And there are some clinical trials currently being planned to confirm that. But that is an issue with any radiation-based treatment, that it is not indefinite. So you have to have a maximum cap of the radiation dose because our human bodies cannot tolerate more than a certain maximum level of radiation exposure. Now, I guess my time is already up, but I'd like to kind of quickly in 5 minutes go over what's coming up the horizon. PRRT is now the mainstream. With Lutathera, we have this fantastic drug to help our neuroendocrine cancer patients. But the next goal is to how to even improve it further. Can we improve the overall responses from 17, 18% to 30%, 40%? Can we improve the median PFS from 30 months to 60 months? Can we reduce the toxicity? Can we reduce the long-term myelotoxicity? So those are the goals. And we are conducting a lot of clinical trials, building on our current success with Lutathera, which I would call the next generation of Lutathera trials, looking at various agents to increase the efficacy or effectiveness of Lutathera. These studies are being done at Markey Cancer Center and some of my great friends at NIH, Oregon, and other centers are doing some of these really awesome studies. Besides these next generation of early phase studies, there are also other larger phase 2 and phase 3 studies being conducted. One of them I'd like to really highlight here is regarding pediatric neuroendocrine tumor study. We recently launched a pediatric neuroendocrine tumor program here, and I'm really excited about it. I did a dual residency in internal medicine and pediatrics. I always wanted to help and cater to our pediatric patients. So I would really appreciate if you can spread the word about our new pediatric net program. There are very few of those in the country, and I'm happy to announce that there is a PRRT clinical trials catering to pediatric patients 12 to 18 years old. So I'm very thankful for the sponsors that they thought about this very rare patient population, and then we can now provide them the access to this drug. Hopefully the trial is positive. But this is going to be open very shortly at Markey Cancer Center and some other centers. Then the other really interesting trial, which is ongoing right now, I'm very excited about, is an international phase 3 clinical trial looking at a new type of PRT agent, which is very much similar to Lutathera, targets somatostatin receptors and uses 177 lutetium as the radionuclide, and is comparing against the Afinitor. So this is a randomized phase 3 trial, and enrolling currently at various centers, including Markey Cancer Center. And the really neat thing about this clinical trial is that at least both study arm as well as the control arms covered by the trial protocol. So lessens the financial toxicity on our patients. So that's really neat about it, and look forward to seeing how this trial pans out. As I mentioned earlier, a lot of novel, really cutting-edge phase 1 trials going on in this space. This is a study with cabozantinib and Lutathera in combination, which Dr. Kennecke and Dr. Mitra are doing in Oregon. My good friend, Dr. Del Rivero and Dr. Lin from NIH is studying PARP inhibitor called olaparib with Lutathera at NIH in Washington, D.C. And we at Markey are leading a couple of novel radiation sensitizer trials, one of which is triapine in combination with Lutathera. So triapine is an oral drug which patients take for 2 weeks during Lutathera treatments. And this is one of the patients who has now finished the treatment and is showing 35% shrinkage in the tumor. Very, very excited about this trial, but this is still ongoing, very early in the development. It'll take some time to read out. Another trial which we are about to launch in about a week to 2 week time is a trial of peposertib, very new drug coming from Germany called DNA PK inhibitor, and we are adding it to Lutathera. Our preclinical data from our labs in pancreatic neuroendocrine tumor models shows very promising data. So we are very excited to start this multi-center study, which we are leading at Markey Cancer Center. And lastly, we are also having a clinical trial looking at Zermelo. That's another really good drug that you've heard about in controlling carcinoid syndrome diarrhea control. But it not only controls the carcinoid syndrome diarrhea, but is very effective in lowering the serotonin level, which we believe also plays as a growth promoter in neuroendocrine tumors. So we are adding telotristat ethyl or Zermelo to Lutathera with the hopes that it will improve on the efficacy or effectiveness of Lutathera and would not add to the side effect profile. With that, I'd like to thank you guys. Thanks for being patient listeners and giving me opportunity to talk to you all. Thank you. And we will take question and answers in Q&A session at 3 o'clock.